Well, greetings everyone, and welcome to the EKG case for the week of May 5th, 2014. This is Amal Mattu at University of Maryland. And this week's case is sent all the way from Oman. Some colleagues and I had gone out to Oman to put together a critical care and emergency cardiology conference several months ago, and we had a chance to meet a lot of great people out there and make some new friends. One of the attendees was Dr. Amal Al-Kashmiri, who sent this EKG, or actually sent this case with a couple of EKGs that I thought we'll have a little fun discussing. So this was a patient in his 60s who presented with shortness of breath. He had a couple of cardiac risk factors. So somebody with all those risk factors, pretty much your emergency department handshake is an electrocardiogram, right? So here's the EKG. And I'll tell you up front, this is primarily going to be a rhythm case, but I did want to completely discuss some of the other findings on the 12-lead EKG from an ischemia standpoint. The patient does have some concerns here, and actually one of the things that Dr. Al-Kashmiri circled is the biphasic T wave down there in one of the inferior leads. Now, we've talked before about how when you have biphasic T waves in the mid-precordial leads, V2, V3, maybe V4 also, that's something that we typically refer to as Wellens or Wellens sign, Wellens syndrome, those biphasic T waves, or frankly, inverted T waves in those leads. You're going to need to worry about proximal LAD occlusion. Well, people haven't really written about this before, but it's certainly been an observation to many of us that when you have biphasic T waves in the inferior leads, well, there's nothing fancy or nothing special about biphasic T's in the mid-precordial leads. If you find them in the inferior leads, you're going to need to worry about right coronary artery subacute occlusion also. And I don't think that this patient ended up having a cath, so we don't know for sure, but it is something that's worth mentioning and being on the lookout for. When you see those biphasic T's in the inferior leads, you have to have some concern about right coronary artery occlusion, even though there's not as much evidence about that as there is evidence pertaining to the mid-precordial leads, right? The other interesting thing that you notice on this 12-lead EKG is that the T waves in V1, V2, maybe V3 also are a little bit disproportionately large. And in a person who's actively having ischemia or cardiopulmonary symptoms, when you see disproportionately large T waves in comparison to the QRS complex, you worry about acute ischemia. That could be what sometimes people refer to as hyperacute T waves. And then there's signs of LVH. There's flipped T waves out laterally, and those appear to be more chronic type of things. Anyway, this patient did not turn out to have an acute coronary syndrome. The main issue with this patient was the rhythm. So now let's switch over and just focus on the rhythm during the rest of the discussion. So you notice, first of all, hopefully you'll notice that sure, there's a sinus rhythm, there's P, QRS, P, QRS, P, QRS, and so on. But there also appears to be P waves that are not being conducted, right? All the way across the EKG rhythm strip, you've got P waves that are not being conducted. And in fact, if you map these out, those P waves do map out with your calipers with the conducted P waves. So this is a completely regular sinus rhythm that goes all the way across. So there's sinus rhythm, there are P waves that are not conducted, and when you see P waves that are not conducted, that are mapping out, you're going to be thinking, is this Mobitz 1? Is this Mobitz 2? Or is this third degree? In other words, is this second degree or third degree AV block? How do you tell the difference? Well, you need to look at the PR intervals, and if the PR intervals are gradually increasing, it's Mobitz 1. If they're saying relatively constant through multiple beats, it's Mobitz 2, and if they're randomly changing, then it's third degree. So I think right off the bat, we can get rid of third degree heart block because the P wave, PR intervals, that is, wherever they are conducted, those are all staying the same. There's no random changing. So this is not third degree. That means this is a second degree AV block, and there's 2 P waves, right? 2 P waves for every 1 QRS complex. And when there's only 2 P waves for every 1 QRS complex, you actually can't really tell if it's Mobitz 1 or Mobitz 2, because you need to have enough PQRS complexes to see whether the PR is increasing or staying constant. And if it's 2-to-1 AV block, you can't really tell whether it's increasing or staying constant. So by convention, when you have second degree AV block with 2-to-1 conduction, you don't bother calling it Mobus 1 or Mobus 2. You simply call it second degree AV block with 2-to-1 conduction. All right, that's the convention that's typically used by the purists in the EKG books out there. All right, so second degree AV block with 2-to-1 conduction. The atrial rate, by the way, is about 75, and so that's your rhythm. And I don't know the patient's blood pressure as to whether this is an unstable bradycardia. Do you need to treat it emergently or just follow it in the hospital or so on? We're not going to get into the treatment here. A little while later, however, the patient's rhythm changed a bit, and now you'll notice that the atrial rate seems to have decreased. So first of all, it's kind of a strange rhythm, and so when you see these strange rhythms, what I like to do is just find the P waves. It looks like, well, that's a pretty certain P wave there, and pretty sure that's a P wave there. But that also looks like a P wave that's just kind of sitting out there. And so once you see a couple of P waves that you're pretty sure are clear-cut, what you do is you take your calipers and just start mapping it out. So there's a P wave interval, and it maps out to that. So that must be a P wave also. And it turns out that maps out perfectly fine to there. And there's another one, maps out to that, which maps out to that, and then that rhythm continues on all the way across the EKG strip. So once again, we've got sinus rhythm. You'll notice that in this EKG compared to the previous one, the atrial rate here is 75. The atrial rate on the new EKG is dropped down to about 60 or so. And that may have been what led to the slight change in the rhythm. Now, once again, we've got P waves that are not being conducted. So is this third degree? Are the PRs randomly changing? Well, maybe not. Maybe so. I don't know. Mobus 1, are the PRs getting longer? Mobus 2, are the PRs staying constant? Let's take a look at the PR intervals. Well, there's a pretty normal looking PR right there. There's a really long PR, and then a P wave that's not conducted. Then the cycle starts over again. Pretty normal looking PR, P wave that's pretty darn long, and then a P wave that's not conducted. And the cycle goes on the same way all the way across. So this is nothing more than simply a Mobus 1 because the PRs are getting longer. And you'll also notice that in this particular case, you've got, let's see, you've got 1, 2, 3 P waves for every 2 QRS complexes before the drop comes, and then you start the cycle over again. So this is a Mobus 1 with what would be called 3-to-2 conduction. In this case, you do have enough P QRS complexes to see that the PR interval is gradually increasing, and then there's a drop. And so for whatever reason, the atrial rate dropped down to 60, which is really low, and you get this really long PR interval. I'm not sure why the PR became so long. At first, in fact, when I saw this rhythm initially, my first thought was that these must be junctional escape beats. The morphology is a little bit different also, but these are probably not junctional escape beats, because if you have junctional escape beats, it resets the sinus cycle, and the P waves would not be mapping out so perfectly if those were junctional escape beats. So these are not junctional escape beats. Those are just conducted beats. They might be conducted a little bit aberrantly or differently, which is what produces the QRS complex changes. But the key thing, once again, is that the PR is gradually increasing before the drop, and that's a consistent finding. And when you have PRs that are consistently expanding before dropped beats, by definition, that must be a Mobus 1, all right? So this is second degree AV block with Mobus 1. And there's a really long PR interval in there, and I'm not really sure what was going on with this particular patient. Maybe the patient got some drugs between that first and second EKG. So anyway, it's a nice couple of EKGs just to provide us a little bit more practice with Brady dysrhythmias and AV blocks. A couple simple take-home points. When you see tough or strange rhythms, sometimes people get very confused and they don't know where to start. Well, what I recommend that you do when you see tough rhythms or strange rhythms, find the P waves and see if they map out. And then just start mapping them out, identify the P waves all across the rhythm strip, and then try to correlate those P waves that you've just mapped out with the QRS complexes. Right? So just take it one step at a time. As we've mentioned before, when you're trying to distinguish between the various AV blocks, you look at the PR intervals. And then, this is not so much of a take-home point, but a question. It may be that biphasic T waves in the inferior leads do correlate with right coronary artery occlusion. I would guess that they do. If anybody out there has come across any good cases of biphasic Ts in the inferior leads, and then you did a cath and found it was a significant right coronary artery occlusion, send them on in, and we'll talk a little bit more about that. We had a great case maybe about 4 or 5 months ago where a patient had biphasic T waves in the inferior leads and sure enough had a nearly complete right coronary artery occlusion. No ST elevation, just biphasic T waves, just like those Wellens in the precordial leads. So anyway, hope that case was helpful. It's always nice to get a little more practice with the AV blocks. People still have a tough time sometimes with the AV blocks, and I really think the reason that people have tough time with the AV blocks is because they don't really know how to start. And so when in doubt, start this way. Find the P waves, map them out first, and then correlate the P waves with the QRS complexes. So I hope that case was helpful, and I look forward to talking to all of you next week. Bye for now.